Next off, we have Lisa Beach. Lisa Beach is a senior physiotherapist in intensive care at the Royal Melbourne Hospital and the cardiorespiratory physiotherapy team leader. Lisa completed a Bachelor of Physiotherapy at La Trobe University in 2005 and her Masters of Physiotherapy cardiorespiratory at the University of Melbourne in 2011. Lisa has over 12 years of clinical experience, predominantly in cardiorespiratory physiotherapy. Lisa's research interests include physical activity, early rehabilitation, outcome measurement, and functional outcomes for patients admitted to the intensive care unit. And she has a number of publications in the area. Thank you, Lisa.
Thank you very much for the introduction, and thank you for the opportunity to present my work looking at our physiotherapy service provision to patients with intensive care unit acquired weakness. I'd like to begin by acknowledging the contribution of my co-authors to this work. So, as wouldn't be new news to those of you in this room, intensive care unit acquired weakness is associated with long-term impairments in physical function and health-related quality of life, and we know these can persist for months to years after hospital discharge. In the ICU, these patients are prioritised to receive regular physiotherapy with the aims of maintaining muscle strength and physical function. Point prevalence data from Australia demonstrates that patients in the ICU for more than 2 days participate in limited mobilisation, and in addition, physical activity levels are low. In 2014, patients with ICU-AW at the RMH ICU and in the acute wards received limited physiotherapy. In 2016, our ICU expanded from 24 beds to 32 beds and moved into a new state-of-the-art facility. In line with this, our physiotherapy staffing ratios improved, and hence we now have a different physiotherapy model of care. The aims of this study were to determine the incidence of ICU-acquired weakness in the RMH ICU and to determine what physiotherapy provision to these patients was like both in ICU and on the acute wards. And we wanted to explore differences in care provision and patient outcomes compared with our observational data in 2014, and that's particularly in relation to increased physiotherapy staffing. This was a prospective observational study conducted from late January to early September this year, and we're still actually recruiting for the study at this time. We screened patients who were mechanically ventilated for at least 48 hours and expected to remain in ICU for 4 days. Patients were included if they had a diagnosis of ICU-acquired weakness, as determined by an MRC sum score of less than 48 out of 60. And major exclusion criteria were head and multi-trauma and acute neurological impairments. And in 2014, we followed the same methodology. Our main outcome measures were physiotherapy rehabilitation interventions. We looked at the number and type patients received in the first 30 days of both ICU and their acute ward stay. As I mentioned, muscle strength was assessed using the MRC sum score, which assesses 6 muscle groups bilaterally using the Oxford grading system to obtain a total score out of 60. Physical function was measured using the Physical Function in Intensive Care Test score, which comprises 2 strength components. It looks at the level of assistance required to move from a sitting to standing position and measures cadence. Highest level of activity was looked at on the ICU mobility scale, which is a hierarchical scale ranging from 0, where patients are doing nothing and lying in the bed, through to 10, mobilising independently. And we also collected medical demographic data, including length of stay and discharge destination. Here we can see the time points of assessment. So baseline assessment occurred at awakening, which was defined as a de Jong of 3 or more out of 5 on 2 consecutive occasions. We measured strength, function, activity level and delirium at this point. The same measures were repeated weekly during the ICU stay and at ICU discharge. In addition, on a daily basis, we collected the number and type of physiotherapy interventions both during the ICU and acute ward stay, and at hospital discharge, we collected the highest level of mobility. Here you can see the patient flow. We screened 338 patients, of whom 259 were ineligible for an MRC assessment. The most common reasons being neurological conditions, multi-trauma or poor prognosis where the patients were not expected to survive the acute ICU stay. We deemed 79 to be eligible for the MRC assessment, and of whom 15 or 19% had a diagnosis of ICU-acquired weakness. In 2014, 88 patients were eligible for an MRC assessment and 25% had a diagnosis of ICU-acquired weakness. Looking at our demographics, on the left-hand side we have our 2018 cohort, in the middle our 2014 cohort, and on the right-hand side some comparative data for all patients admitted to our intensive care unit. As you can see, the groups are quite different on a number of parameters, with a higher percentage of surgical patients in 2018 and a higher percentage of medical patients in 2014. The 2018 cohort were not as unwell, with a mean Apache 2 score of 18 compared with 24 in 2014. And 2018 data was much closer to our overall patient cohort. In addition, both groups, which is probably no surprise to those in the room, had a prolonged ICU length of stay at a median of 13 days in 2014 and 2018, and 19 days in 2014. And there was also variability seen in discharge destination, with a higher percentage of patients discharged directly home in 2018. In terms of strength and physical function, we saw significant improvements in both strength and physical function from awakening to ICU discharge. These findings were statistically significant for both our 2018 and 2014 data. However, you will note that the 2018 group had better strength and function at baseline. In addition, at ICU discharge for both groups, only just over 25% had mobilised away from the bedside at ICU discharge. So this, combined with the strength and function scores we can see, demonstrates that patients still have significant impairments at ICU discharge. In terms of our physiotherapy service provision, we were able to provide 157 rehabilitation interventions in the ICU and almost 200 interventions on the acute ward. The median number of interventions provided in the ICU per awake day was 1.25, and this increased from a median of 0.9 in 2014. On the acute wards, patients received a median of 0.5 physiotherapy interventions per day, or they were seen every second day. And those of you familiar with the acute hospital system would be aware that most hospitals have a prioritised weekend service, and many of these patients wouldn't meet the criteria for review over the weekend. In terms of what we actually did, as you can see, these patients are resource intensive to treat, so 2/3 required 2 therapists in 2018, and almost 60% also needed 2 therapists to treat in 2014. The most common interventions were sitting on the edge of the bed, passively transferring to sit out of bed, and completing active exercises in 2018. In 2014, it was sitting on the edge of the bed and completing active exercise. On the ward, once again, a number of these patients still require 2 therapists to treat, with slightly more in 2000. I wouldn't know if I say slightly more, but quite a few more needing 2 therapists to treat in 2018. And the most common interventions start to become a little bit more high level, which we might expect, being walking and standing in 2018, walking, actively sitting out of bed, and sitting on the edge of the bed in 2014. So we had a lower incidence of ICU-acquired weakness in our 2018 cohort compared with 2014 data and published reports. We know that they were less unwell as measured by their Apache 2 score, and they had a shorter length of ICU stay. It's promising that with increased physiotherapy staffing, we are able to provide more interventions to these patients whilst they're awake and in the ICU. However, they're still spending a significant portion of their ICU sedated and participating in limited activity, which raises the question, do we need to review sedation practices in our unit? Or do we need to look at interventions that we can implement in this phase when patients are unable to participate actively? These patients still have significant impairments at ICU discharge, so as we've heard already throughout this conference, we may need to consider the type, dosage and frequency of interventions provided. As you may have noted, a higher proportion of patients were passively transferred out of bed in 2018. In 2014, this actually accounted for less than 10% of all physiotherapy interventions in ICU, which raises the question, are we doing this in addition to other physiotherapy treatments, or are we actually doing this instead of more active forms of physiotherapy intervention. Another factor that may have impacted this was we moved to a new state-of-the-art unit with the availability of overhead tracking at every bedside. We had better seating to use for our patients, and we had more staff to be able to move these patients. This was obviously an audit conducted at a single site over 2 time points. The data was not compared statistically between the time points. So in conclusion, this small sample of patients with ICU-acquired weakness had a prolonged length of stay, they're resource intensive to treat, and they still received limited physio in the ICU and on the ward. With increased physio staffing, we can provide more interventions to these patients whilst awake in the ICU. And I think future studies should investigate the most effective rehabilitation interventions and dosage, strategies to reduce sedation or interventions that we can use during this phase, and it would be fantastic if we could predict who was likely to develop ICU-acquired weakness. Thank you.
Thanks, Lisa. Any questions?
Lisa, thanks for a nice talk. It's just interesting that your 2018 ward patients had a greater percentage requiring 2 physios to treat them,
Yes.
yet were stronger
Yeah,
and
that's
better
right.
beforehand. So is there any reason behind that? Can you?
We have talked about this a little bit in our team. I think they actually had similar scores at ICU discharge, so despite being stronger at awakening and us giving them more physio, they only reached a similar level at ICU discharge. So maybe we're not doing the right thing with them. It's also hard to say with the type of study design, you know, do we actually have more physio staffing on the ward? We haven't had a specific increase, but there have been some small amounts of increase in staffing in the acute ward since that time, so that could also impact. And as could things like our culture around staff safety and the management of and movement of these patients. Yeah.
Any further questions?
Lisa, what do you put down? That's quite a significant difference in Apache 2 scores.
Yes.
Did you also account for other, was delirium different, was sedation different? Were there other factors that were different other than, the surgical cohort will bring the Apache down, but...
The most common difference that we saw was in the high presence of the surgical cohort. One of the reasons I can think of that may account for that increase, when we built our new intensive care unit, we also became the intensive care unit for Peter Mac, or the Victorian Comprehensive Cancer Centre, and we see a lot more fairly routine surgical patients coming through our ICU, so that could influence that. They were actually quite similar in terms of the presence of delirium, both around just over 50% of patients had delirium, but I think it would be really interesting to know why they're not as sick. That there are a couple of the things that I can think of that may have impacted that.
And from a clinical perspective, do you think ICU survivors should actually warrant physiotherapy treatment on weekends, given we know their burden of recovery?
I think based on what we've heard today, I think absolutely we could make a good case for them warranting ongoing rehabilitation interventions, and they're a really tricky group to prioritise in what we know are resource-limited environments, because they may be comparatively functioning quite well compared to some of our other patients, but these patients actually have a significant reduction in their functioning and quality of life compared to what their baseline was. So in an ideal world, absolutely, but I think we all work in the challenging situation of managing limited resources and working out how do we distribute those across all the patients within the healthcare system.
Any other questions for Lisa? Thanks very much, Lisa.
Thank you.